Welcome back to Open Med School. In the last session, we had discussed about GBS and explained the pathogenesis, that is the molecular mimicry leading on to AIDP and MI. So today we'll be discussing a case scenario and discuss how we'll triage the patient. So this is the history of the patient, a 42-year-old patient with a 3 days history of bilateral lower limb weakness. So point to be remembered, the patient has got a bilateral lower limb weakness. That is, it is symmetrical weakness, preceded by some sensory complaint, that is numbness. And 10 days back, patient had a history of respiratory infection. On examination, he has got MRC 3/5 in upper limbs and lower limbs and 4/5 in the upper limbs. So patient has got paraparesis predominantly. He has got difficulty in swallowing, and his respiratory rate was 28 per minute. That is tachypnea. The forced vital capacity is 800 ml. That is normal is around 3 liters. His BP was fluctuating 160, 100, 90/60, and he has got tachycardia. Single breath count was less than 15. So obviously this patient is having a paraparesis, symmetrical weakness, or a quadriparesis, and he has got bulbar involvement, as evidenced by difficulty in swallowing and bifacial weakness. So the point to be remembered is that the patient like this, that is bulbar weakness with facial paresis, this indicates bad prognosis because the patient is going to develop respiratory distress. So the key principle is all GBS patients should be admitted, assessed, and anticipate respiratory difficulty. So what are the initial assessment and how will you monitor such patient? A complete neurological examination, especially the muscle grading. Second point, you will be looking at the bulbar function, the swallowing function. Third, you'll be looking at the respiratory muscles. So assessing the bulbar, facial, and neck muscles. So ask the patient to flex the neck and see, apply some resistance and see whether the patient's, what is the power of the neck muscles. So involvement of these three muscles, that is bulbar, facial, and neck muscle weakness, suggests bad prognosis. That is point to be remembered. Then you assess the swallowing function. Again, it is an indication of the bulbar function. So look at this and see. So complete examination, MRC grading, the assess the bulbar, facial, and neck muscle strength, speech and swallowing function, and assess the cough reflex. So these are the things that you should assess. Now once you assess the neurological examination or assessment, the next important or the most important thing is the ventilatory status. Measure and monitor one, respiratory rate. Second is SpO2. Third is, if facilities are there, check the forced vital capacity. Forced vital capacity less than 1 liter indicates a need for intubation. So third point is hemodynamic monitoring. So neurological monitoring, ventilatory assessment, and hemodynamic, because autonomic dysfunction is very common. Autonomic dysfunction leads on to fluctuations of blood pressure, development of arrhythmias, bradycardia, tachycardia, or even cardiac arrest can occur. That is important. So labile blood pressure, autonomic storm can occur. So close monitoring of the heart rate rhythm is essential. So ICU admission is indicated in such cases. That is, when there is impending respiratory failure is there, go for ICU admission. So what are the red flags that you should look for? One is, first and foremost, is the respiratory rate. Respiratory rate more than 30 Should be very careful. Use of accessory muscles of respiration. And third, inability to count for in single breath, inability to count for 15. Of course, investigation, ABG analysis abnormalities, and forced vital capacity less than 1 liter. These are the red flags. So when you say single breath count, you ask the patient to count for, take a deep breath, and ask them to count without interruption minimum 15. So give a target more than 15, then only the patient will be trying to count it. So keep these points: respiratory rate, use accessory muscles, inability to count in single breath count. Single breath count is a very useful bedside clinic in resource poor settings. So once you do this, there are other scores like EGRI score, that is to assess the respiratory failure risk. So about which we will discuss in another time. So next is we will be looking about we have already said about the autonomic instability. Always remember this point. The autonomic instability can lead on to bladder dysfunction. Urinary retention can occur. Though it is very uncommon in GBS, whenever you get a bladder dysfunction in GBS, always think about alternate causes like a transverse myelitis. Patients without respiratory compromise, or patients not having any bulbar weakness, or swallowing difficulty, you can manage the patient high dependency care. And patients with stable patients, mild weakness, stable over the last 72 hours, again, you may treat the patient in the general ward. So we will review the case. Our patient has got respiratory failure, bulbar involvement, autonomic dysfunction. He has got a forced vital capacity less than 1 liter. Autonomic signs are present. He needs ICU care. So you understood which are the cases to be admitted. So key take-home messages. Most important, GBS is a disease where yesterday's normal patient or today's normal patient may develop respiratory failure and tomorrow will be on ventilator. So beware of that. Try the patient early. ICU admission is based on the risk of respiratory failure, autonomic dysfunction. So monitor the patient properly. Don't wait for respiratory arrest. Anticipate it and plan for mechanical ventilation. So in the next session, we'll be discussing on the management of GBS, the immunotherapy, and supportive care. Stay tuned. Hope this was useful to you. Thank you.